causing severe hemorrhage and fetal death. A complication of both placenta previa and abruptio placenta is disseminated intravascular coagulopathy, or DIC. You must be absolutely precise in your assessment of a woman who has suffered severe hemorrhage. Signs and symptoms of DIC include bleeding of the gums and from injection sites, along with a rapid pulse. The skin may have purple areas or purpura with petechiae. Your client may be restless or upset and say something like, "I think I'm going to die," or "Something is very wrong and I'm scared." When the client expresses feelings of doom, you must take this seriously and provide emotional support. If your client is in labor, the fetal monitor may show late decelerations, fetal tachycardia, and little or no variability. These are signs of shock in the mother and in the fetus, but early recognition is the key to improving otherwise poor fetal and maternal outcomes. Nursing interventions and assessment for the client who has DIC are accurate intake and output, fluid replacement, hemodynamic monitoring via Swan-Ganz catheter, and careful estimation of blood loss. Nursing assessment with DIC also includes the indication of any alteration in mental status or confusion on the part of the client, pulmonary dysfunction related to dyspnea, tachypnea, and cyanosis, and liver dysfunction evidenced by jaundice and hepatomegaly. Rubella, also called German measles, is one of the torch infections acquired during pregnancy. This highly infectious viral disease has devastating effects on the fetus during the first and second trimesters of pregnancy. The possibilities include defective organ formation, blindness, hearing loss, heart disease, mental retardation, and demise. The type of fetal defect is directly related to the timing of maternal exposure. Pregnant women should not receive the rubella vaccine because of the theoretical possibility of developing a rubella infection from the live virus while pregnant. However, women who are of childbearing age should definitely be immunized against rubella. If a woman's rubella titer is high enough, she is considered immune and does not need a vaccine. However, a non-pregnant woman with a low titer should receive the vaccine. After immunization, she should avoid pregnancy for 3 months to prevent rubella-related problems in the fetus. Substance abuse continues to be a major problem from many perspectives. It is defined in pregnancy as any use of alcohol or illicit drugs that causes physical, social, or interpersonal problems. Any use of alcohol or illicit drugs during pregnancies is considered abuse because of the serious effect these substances have on the fetus and neonate. Such substances include nicotine, alcohol, cocaine, marijuana, narcotics, hallucinogens, stimulants, sedatives, tranquilizers, and pain relievers. Substance abuse during the first trimester places the fetus at greatest risk, variable with strength, amount, frequency, and route of administration. You should screen every pregnant woman for substance abuse, at least verbally during the history taking, so that intervention can begin early in the pregnancy for those women who disclose patterns of substance abuse. One major problem with women who abuse drugs during pregnancy is that they tend to avoid prenatal care. If you suspect the use of drugs, ask, "Are you taking any medications prescribed for you?" How about other prescriptive medication not ordered by your healthcare provider? Do you use any street drugs like cocaine or heroin? Are you in a drug or alcohol treatment program or on methadone? Substance abuse can be verified with maternal toxicology screening. Look for these physical and behavioral findings associated with maternal addiction: constricted pupils, dental caries, mood swings, rhinitis, frequent falls or accidents, anorexia, weight loss, poor hygiene, no prenatal care, irregular fast heart rate, and the reoccurrence of sexually transmitted diseases, or outward signs of physical violence. Maternal complications of substance abuse during pregnancy are high blood pressure, anemia, nutritional deficiencies, pancreatitis, alcohol-induced hepatitis, and liver cirrhosis. Complications for the fetus and newborn are many, depending on the specific substance involved. For example, if your client takes cocaine, heroin, or amphetamines, the fetus will have intrauterine growth retardation. A common side effect of cocaine use is abruptio placenta. If alcohol is the substance abused, then signs of fetal alcohol syndrome will be apparent. These are prenatal and postnatal growth restriction, central nervous system malfunctions, and characteristic features such as microcephaly, small eyes, a flattened nasal bridge, and a thin upper lip. Learning delays and behavioral abnormalities such as attention deficit disorder, or ADHD, and oppositional defiant disorder are more common among children exposed to alcohol prenatally. Again, depending on the substance abused, signs of drug withdrawal will appear in the newborn soon after birth. Initially, the newborn might be listless and have poor muscle tone and poor feeding habits, such as uncoordinated suck and swallow. Other characteristics include a high-pitched cry, jitteriness and tremors, restless sleeping, and an inability to be consoled when crying. Keep in mind that the substances most often abused during pregnancy are tobacco and alcohol. Your interventions must focus on teaching the client about the consequences of exposing her fetus to all lethal substances. Finally, let's shift our attention to adolescent pregnancy. The United States has the highest incidence of adolescent pregnancy among Western countries, and most of these teenage pregnancies are unintentional. Adolescents are less likely to seek early prenatal care and are more likely to be non-compliant in the areas of nutrition and prenatal care. As a result, teens are at a higher risk for pregnancy-induced hypertension, preterm birth, and intrauterine growth restriction. Psychosocial risk factors affecting teens in general are transient relationships, single-parent families, disrupted education, and low income. Factors contributing to teenage pregnancy include cohabitation, early sexual activity, poverty, low self-esteem, risk-taking behaviors, reduced impulse control, diminished ability to delay sexual gratification,